Seniors, your body already produces its own version of Ozempic. It has been doing it your entire life. Nobody in that 10-minute appointment has ever explained how to activate it. That changes right now. I'm Dr. Michael Reed, internal medicine physician and metabolic health specialist, watching type 2 diabetic patients follow every protocol their doctors prescribed, the medication adjustments, the quarterly A1C checks that only moved in one direction, the same eat less, move more handout year after year, and still getting worse. I went deeper into the science. What I found made me angry, not at individual doctors, at the gap between what the research actually shows and what reaches a patient in an exam room. That gap is costing people their independence and, in too many cases, their lives. This video exists to close it. Today I'm going to show you 4 metabolic mechanisms that are keeping your blood sugar stuck, with the peer-reviewed studies behind each one. Then I will give you a specific protocol, timing, amounts, the biological reason each step works. And I'm going to tell you something the pharmaceutical conversation about diabetes consistently omits, that type 2 diabetes has been shown in a landmark clinical trial to go into full remission, in people your age, without surgery, without a new drug. If this is the kind of information you have been looking for, subscribe, not for the numbers, because there are millions of people managing type 2 diabetes who have never been told what you are about to hear. Let's start with the hormone at the center of everything. There is a molecule your intestine makes every time you eat. It is called GLP-1, glucagon-like peptide 1. You have probably heard that name because it is the mechanism that made Ozempic and Wegovy famous. Semaglutide, the drug in those injections, does one primary thing. It acts like GLP-1 in your body. It tells the pancreas to release insulin only when glucose is actually present. It slows gastric emptying so glucose enters the bloodstream gradually. It signals the brain that you are satisfied, and it quiets the liver so it stops releasing stored glucose when it should not. That is a remarkably useful hormone. Your body makes it for free. The question the pharmaceutical industry would rather not emphasize: why isn't yours working the way it should? In the lining of your small intestine, there are specialized cells called L cells. Their job is to sense what you are eating and release GLP-1. When they work properly, they fire every time you consume fiber, protein, or healthy fat. In type 2 diabetes and insulin resistance, those L cells become dysfunctional. They release less GLP-1, insulin response becomes uncoordinated, blood sugar spikes higher and stays elevated longer. The liver misses its signal and keeps releasing glucose. Ozempic bypasses the factory, delivering synthetic GLP-1 at pharmacological concentrations designed to last days instead of the natural hormone's few minutes. The drug works, but at roughly $1,100 per month, weekly injections, and a documented reversal of benefits once you stop, a 2022 study in diabetes, obesity, and metabolism confirmed that most patients regained lost metabolic ground within 1 year of discontinuation. It is managing dysfunction, not correcting it. What the research now shows is that the same L-cell pathway can be stimulated through specific dietary compounds, specific movement patterns, and at least one supplement with a clinical evidence base that rivals early metformin trials. We are getting to all of it. But first you need to understand the full picture. There are 4 mechanisms keeping your blood sugar stuck. Your current treatment is probably only addressing one. The first is what I call the liver leak. A significant portion of your fasting morning blood sugar, that number you check before breakfast, does not come from food you ate the night before. It comes from your liver. During the night, your liver runs gluconeogenesis. It manufactures new glucose and releases it into your bloodstream to fuel your brain while you sleep. In a healthy metabolic state, insulin tells the liver when to stop. It stops. In type 2 diabetes, the liver has become resistant to that signal. It keeps producing and releasing glucose all night, even when your blood is already fully supplied. You wake up with a number that makes no sense given what you ate for dinner. That is your liver not listening to insulin. A 2020 meta-analysis in diabetes research and clinical practice, synthesizing 41 studies, found that hepatic insulin resistance is both more prevalent and more severe in adults over 60 compared to younger patients with the same body mass index and the same duration of diabetes. The mechanism involves visceral fat, the fat accumulated around your abdominal organs, continuously releasing free fatty acids and inflammatory compounds that travel directly to the liver through the portal vein. They disrupt the insulin signaling pathway at the molecular level, and the liver loses its ability to hear the stop signal. You do not need to appear overweight for this to be happening. A person at normal body weight can carry significant visceral fat accumulation after decades of refined carbohydrates. The second mechanism compounds the first. I call it the dawn surge. Even if you manage the liver leak, a secondary wave hits between 4 and 8 in the morning that most treatment plans never account for. Your body naturally releases a surge of counter-regulatory hormones: cortisol, growth hormone, glucagon. In people without metabolic dysfunction, these are counterbalanced by a simultaneous rise in insulin sensitivity. In type 2 diabetes, the hormones fire normally, but the sensitivity does not rise to meet them. The result is another burst of hepatic glucose production right as you wake up. Many patients tell me they were careful all evening and still woke up in the 130s or 140s. They did not do anything wrong. Their dawn surge is not being compensated. Standard management often adds or increases evening medication to address this. What the research now suggests is that timed behavioral interventions reduce the amplitude of that dawn surge more effectively than simply increasing pharmacological load. A 2019 study in the Journal of Clinical Endocrinology and Metabolism followed adults with type 2 diabetes, mean age 61, who combined a low glycemic evening eating pattern with a 10-minute post-dinner walk. Fasting morning glucose fell by an average of 18 milligrams per deciliter at the 4-week mark, not through a medication change. Through timing, the dawn surge is amplified by fragmented sleep, waking multiple times per night, which elevates cortisol output and layers on top of the first mechanism. If you also have untreated sleep apnea, a condition far more prevalent in adults over 60 than most people realize, the two compound. CPAP therapy in patients with obstructive sleep apnea has produced measurable A1C improvements without any other intervention. That connection rarely surfaces in a standard diabetes appointment. The third mechanism is the one I am most passionate about explaining because it is the most consistently ignored. I call it the muscle drain. Skeletal muscle is the largest glucose-consuming tissue in your body. After a meal, when insulin rises, muscle handles approximately 75 to 80% of total glucose uptake. Every gram of glucose that disappears from your bloodstream after eating goes primarily into muscle cells. Muscle is your blood sugar buffer. After 50, humans lose 1 to 2% of their muscle mass per year without specific resistance training. This is sarcopenia. It is not a disease. It is a metabolic consequence of aging that affects virtually everyone who does not actively fight it. And what sarcopenia means for blood sugar is direct. Every year, the sponge absorbing your postprandial glucose gets smaller. Less muscle, less glucose clearance, higher spikes, more insulin demand, more demand, faster beta cell exhaustion. When did your doctor last prescribe a specific resistance exercise protocol for your diabetes? Not a suggestion to move more. A prescription for muscle-loading exercise with the biological explanation behind it. For most patients I have spoken with over 25 years, the answer is rarely or never. A 2020 randomized controlled trial in diabetes care followed 82 adults with type 2 diabetes, age range 55 to 73, through 12 weeks of resistance training 3 times per week. HbA1c dropped 0.57%. Fasting glucose dropped 14.2 milligrams per deciliter. These were sedentary older adults doing chair squats and resistance bands. Accessible exercise. Real outcomes. The ADA acknowledges the evidence. The clinical workflow rarely prioritizes the conversation. The fourth mechanism underlies all the others. I call it the inflammatory fire. There is a condition documented across aging biology research called inflammaging, a chronic low-grade systemic inflammation with no pain, no swelling, no fever. Just measurable elevations in interleukin-6, tumor necrosis factor alpha, and C-reactive protein that correlate directly with the severity of insulin resistance in older adults. Visceral fat is not inert tissue. It secretes pro-inflammatory cytokines continuously. Those cytokines enter circulation, and they interfere with the insulin receptor signaling cascade inside both muscle and liver cells at the molecular level. Every unit of systemic inflammation you carry translates into measurable insulin resistance. A 2023 umbrella meta-analysis in clinical pharmacology and therapeutics, synthesizing multiple prior meta-analyses, the highest tier of evidence available, confirmed that berberine supplementation produced significant reductions in IL-6, TNF-alpha, and C-reactive protein in patients with metabolic disorders. IL-6 fell by a standardized mean difference of negative 1.23, TNF-alpha by negative 1.04. These are the same inflammatory markers semaglutide is documented to reduce. Berberine accomplishes a meaningful portion of that effect through a different biochemical pathway at a fraction of the cost. Now you have the full picture. The liver leak, the dawn surge compounding it, the muscle drain limiting your clearance after meals, and the inflammatory fire impairing insulin receptor function throughout. 4 mechanisms, 1 miserable number. Most treatment plans address the surface reading, not the cascade producing it. Your doctor is not failing you intentionally. A standard appointment is 11 minutes. The management protocol, check A1C, adjust medication, was built for efficiency at scale. The research I have cited is real, published, and accessible. The problem is translation. That gap is what this channel exists to close. Enough about the mechanism. Here is what to do. The first intervention targets both the liver leak and the dawn surge simultaneously, and it costs nothing. The first intervention targets both the liver leak and the dawn surge simultaneously, and it costs nothing. Researchers at George Washington University, led by Dr. Loretta DiPietro, studied adults aged 60 and older at risk for impaired glucose tolerance in a controlled calorimetry setting. Published in Diabetes Care in 2013, 3 15-minute walks taken after breakfast, after lunch, and after dinner were more effective at lowering 24-hour blood glucose than a single 45-minute walk at any other point in the day. Same total time, different metabolic result, because the timing aligned muscle glucose uptake with the exact moments blood was highest. A 2016 study in Diabetologia by University of Otago researchers replicated this specifically in adults with established type 2 diabetes, average age 60, diabetes duration of 10 years. Those who walked 10 minutes after each meal showed a 12% greater reduction in post-meal glucose than those doing a single 30-minute walk. The mechanism: contracting muscle absorbs glucose via GLUT4 transporters that activate independently of insulin. Muscle in motion pulls glucose out of circulation without needing the insulin key. In the evening, this directly limits the substrate available for overnight hepatic glucose production, which is why consistent post-dinner walkers see their fasting morning number change within 2 to 3 weeks. Practical prescription: within 30 minutes of finishing any major meal, walk 10 to 15 minutes at a comfortable pace. If mobility is limited, seated leg raises or resistance band work from a chair produces a meaningful portion of the same effect. Muscle contraction after eating is the principle. The form is secondary. The second intervention restores the GLP-1 deficit at its source. A 2015 study from Wolfson Medical Center in Israel, published in Diabetologia, followed 93 adults with type 2 diabetes through a dietary intervention that front-loaded protein at breakfast. Those who consumed 30 or more grams of protein before 7:30 in the morning showed significantly reduced postprandial glucose spikes not only at breakfast, but at lunch and dinner as well. The mechanism is called the second meal effect. Elevated GLP-1 secretion triggered by morning protein persists through the day and primes the L-cell response for subsequent meals. 30 grams of protein at breakfast is not complicated. 2 large eggs, half a cup of Greek yogurt, and a small portion of smoked salmon gets you there. What it is not is toast with jam, cereal, orange juice, or a bagel, the classic American senior breakfast that spikes glucose within 20 minutes and suppresses GLP-1 function for hours. The companion piece is soluble fiber: beta-glucan from oats, psyllium husk, flaxseed, apple pectin. These are fermented in the colon into short-chain fatty acids that bind to receptors on your intestinal L cells and directly trigger GLP-1 secretion. You are giving the hormone factory its raw materials. A 2020 meta-analysis in the American Journal of Clinical Nutrition confirmed that higher soluble fiber intake was significantly associated with elevated postprandial GLP-1 responses in adults with type 2 diabetes. 1 tablespoon of psyllium husk in a full glass of water, 15 minutes before your largest meal, applied consistently over 8 weeks. A 2009 study by James Anderson showed it reduced HbA1c by 0.84% as a standalone intervention. The target is 25 to 35 grams of total daily fiber. The average American with type 2 diabetes is getting about 14. You do not need to overhaul your diet to close that gap. You need to add one high-fiber habit daily and make it consistent. There is also the matter of food sequencing, and the research on this is more rigorous than people expect. A 2017 study in diabetes care by Dr. Alpana Shukla at Weill Cornell examined adults with type 2 diabetes eating the identical meal. Same calories, same macronutrients, but in different orders. Vegetables and protein first, carbohydrates last. Postprandial glucose dropped 29%, peak glucose dropped 37%. The physical presence of fiber and protein in the stomach slows gastric emptying and blunts the absorption rate of carbohydrates that follow. Zero cost, zero prescription. Applicable at your next meal. Now berberine, because this is where the GLP-1 activation protocol and the liver leak intervention converge in a single compound with a clinical evidence base most people never expect to find. Berberine activates AMPK, adenosine monophosphate activated protein kinase, the enzyme often called the master metabolic switch. When AMPK fires, it reduces hepatic glucose production, increases glucose uptake in muscle, improves mitochondrial function, and suppresses the inflammatory cytokines that impair insulin signaling. Metformin, the most prescribed diabetes medication in the world, works primarily through hepatic AMPK activation. Berberine activates AMPK in the liver, the muscle, and the intestinal cells simultaneously. In 2008, researchers at Shanghai Jiaotong University School of Medicine published a randomized controlled trial in the journal Metabolism comparing berberine directly against metformin in 84 type 2 diabetic adults over 13 weeks. Berberine reduced HbA1c from 9.5% to 7.5%, a 2-point drop. Fasting plasma glucose fell from 10.6 to 6.9 millimoles per liter. Postprandial glucose from 19.8 to 11.1. HOMA-IR, the index of insulin resistance, dropped by 44.7%. The outcomes were statistically equivalent to metformin. A 2022 systematic review in Frontiers in Endocrinology analyzed 37 randomized trials across more than 3,000 patients. Pooled result: berberine reduced fasting plasma glucose by 0.82 millimoles per liter and HbA1c by 0.63% versus placebo. A 2024 update in Frontiers in Pharmacology, 50 RCTs over 4,000 patients, confirmed and strengthened those findings. The clinical dose across the majority of these trials is 500 milligrams taken 2 to 3 times daily with meals. Start with 1 dose per day and increase over 2 weeks to reduce gastrointestinal adjustment symptoms. Safety note. And I am going to be direct because this matters. Berberine and metformin work through overlapping mechanisms. If you are on metformin, adding berberine has an additive glucose-lowering effect that requires increased home monitoring. If you are on insulin or sulfonylureas, medications like glipizide, glimepiride, or glibenclamide, the additive effect carries genuine hypoglycemia risk. In seniors, hypoglycemia means falls, fractures, and cardiac arrhythmias. Do not add berberine to an existing insulin or sulfonylurea regimen without informing your physician and establishing a monitoring plan. The interaction is documented, the risk is manageable, but it requires medical awareness, not self-management in isolation. One more deficiency worth addressing: magnesium. Magnesium is a cofactor in over 300 enzymatic reactions, including multiple steps in the insulin signaling cascade. When intracellular magnesium is low, insulin receptor function is mechanistically impaired. Adults with type 2 diabetes have magnesium deficiency at 2 to 3 times the rate of the general population. And the medications that most commonly deplete magnesium are among the most frequently prescribed to people in this age group. Proton pump inhibitors for reflux, loop diuretics for blood pressure or heart failure, and long-term metformin. If you are on any of those, there is a meaningful probability your levels are suboptimal. Form matters. Magnesium glycinate has significantly better bioavailability than the magnesium oxide in most budget supplements. 300 to 400 milligrams in the evening is the range supported by evidence. If your kidney function is impaired, eGFR below 45, do not supplement magnesium without specific medical guidance. This is non-negotiable. Here is the practical structure that brings everything together. In the morning, Front-load protein at breakfast, 25 to 30 grams, before any carbohydrate. A tablespoon of psyllium husk in water 15 minutes before eating accelerates the GLP-1 response. Take berberine with the meal if you are incorporating it. Within 30 minutes of finishing, take a 10 to 15-minute walk. At every meal, sequence the plate. Vegetables first, protein and fat second, carbohydrates last and smaller. This is not about eliminating anything. It is about sequencing the same food differently. In the evening, dinner should carry the lightest carbohydrate load of your day. Protein, non-starchy vegetables, modest whole food carbohydrates. Post-dinner walk within 30 minutes. Magnesium glycinate, 300 to 400 milligrams of the glycinate form, not oxide, before bed. If your eGFR is below 45, do not supplement magnesium without specific medical guidance. Resistance training twice a week from a chair. Squats with support, wall push-ups, resistance bands, 15 minutes. Consistent. After 6 to 12 weeks, the muscle glucose buffer begins to recover. Treat sleep as a metabolic intervention, 7 to 8 hours, cool and dark, screens off an hour before. If you snore heavily or wake to urinate more than twice, mention sleep apnea to your physician. CPAP therapy has produced measurable A1C improvement in patients with obstructive apnea without any other change. Let me close with the thing I most want you to take from this. Type 2 diabetes was called irreversible for 4 decades. In 2018, the DIRECT trial, published in The Lancet, challenged that directly. 298 adults with type 2 diabetes, ages 51 to 72. No surgery, no new medications, dietary modification, and structured support. At 2 years, 36% achieved complete remission, HbA1c below 6.5% with no diabetes medication. The mechanism, reversal of ectopic fat accumulation in the liver and pancreas, restoring beta cell function and hepatic insulin sensitivity. The same mechanisms we have been discussing. The biology responded. Remission is not guaranteed for every person. Duration of diabetes, remaining beta cell function, and individual factors all matter. But the direction of causality has been established. Type 2 diabetes is not a one-way street. The interventions are not exotic. They are the inputs that activate the machinery your body already has. The L-cell GLP-1 system, the AMPK switch in liver and muscle, the post-meal glucose buffer in skeletal muscle, and the inflammatory cascade that either quiets or intensifies based on what you give it. After your next meal, take a 10-minute walk. At that same meal, eat the vegetables first and the carbohydrates last. This week, rebuild breakfast around protein. If you are on metformin, insulin, or any diabetes medication, do not change that medication based on this video. Work with your physician. Show them the research. As your numbers improve, and with consistency, they will, your medication needs may change. That conversation belongs in a medical office. Seniors, your metabolism is not broken. It has been given the wrong instructions. Now you have the right ones. This is Dr. Michael Reed. Know your numbers. Own your health.